going to talk with you about the results of a qualitative study that we did on sickle cell disease stigma in 3 African countries, and then describe strategies for addressing sickle cell disease related stigma. So health-related stigma is a form of devaluation, and it's based on a health condition. A useful way to frame the levels of health-related stigma is the social ecological perspective. So you have structural stigma on the outside, which are the negative attitudes, beliefs, and practices that happen in systems, such as the healthcare system, the educational system, the employment system. In the community, you have negative attitudes, beliefs, and practices. And then external stigma is related to negative attitudes, beliefs, and practices directed interpersonally to the person who's being stigmatized. And finally, internalized stigma is what happens when we start to believe the negative attitudes, beliefs, and practices, and it becomes part of how we see ourselves. So the World Health Organization recently has focused on health-related stigma in the context of COVID-19. But individuals with sickle cell disease in the US often report being dehumanized, particularly when seeking care for pain. And the fact that sickle cell disease affects primarily Blacks and African Americans in the US contributes to this stigmatization. But around the world, individuals might actually experience physical violence or denial of healthcare, education, housing, employment. So what we'll be looking at, again, are results from these study that we did in 3 countries in Africa, but I'm also as well going to be reviewing how things are in the US. So, and in higher income countries. So Dominique Bulgin outlined domains of sickle cell race-based stigma in a systematic review. And she identified 4 domains from 27 studies. First, the social consequences of stigma that referred to the effects on social interactions, activities, and status. Then the effects of stigma on psychological well-being. So this is the influence on mental health and quality of life, but also recognizing that stigma creates stress. And so that's going to influence psychosocial well-being. There are effects of stigma on physiological well-being. In sickle cell disease, these can be direct, so that in fact, pain experience is exacerbated when a person is subjected to stigma. But it can also be indirect. So when a person delays seeking acute care, then they have consequences downstream. Impacts of stigma on patient-provider relationships and care-seeking behaviors is something very specific to sickle cell disease, where there's an influence on interactions between the patients and families and their providers, and this in turn creates mistrust and certain type of decision-making among individuals with sickle cell disease and their family, which may mean that they delay seeking care or don't seek care at all. This study, important study related to stigmatizing language. So sometimes a form of stigma against people with sickle cell disease is calling them, labeling them such as frequent flyers, sicklers, drug addicts, substance abusers. So this was a study where 413 interns and residents reported on their attitudes towards a hypothetical patient with sickle cell disease. They were randomized to one of 2 chart notes containing stigmatized or neutral language. And the PASS is an attitudinal scale. And what you can see is that when they were exposed to neutral language, they were significantly more positive about people with sickle cell disease in their attitudes. When they were exposed to stigmatizing language, again, they were significantly more negative in their attitudes. They were also asked, how aggressive would you be in your pain management? And when they were exposed to neutral language, they were significantly more aggressive in their pain management. The stigmatizing language led to less aggressive pain management. So again, you can see that in this experimental design, that stigmatizing language did have a significant effect. So, but what's the impact in real life? So in a review of 170,000 emergency department visit records to determine wait times to see a physician for patients with sickle cell disease, and these were compared with long bone fracture and all other conditions, the patients with sickle cell disease experience wait times 25% longer than the general patient population. And this difference in a regression model was explained by their African American race. But patients with sickle cell disease also waited 50% longer than patients with long bone fracture, even after accounting for race and assigned triage priority. So on the side of the patient and their experience, you can think about stigma as pain-related injustice. So a patient sees that they are being unjustly treated when they're seeking relief from pain. So these are children 8 to 17 years of age. They reported worse pain, greater pain catastrophizing, greater functional disability, and emotional distress when they rated their pain-related injustice appraisals as higher. And there was an interaction between age, gender, and racial bias, with older girls with sickle cell disease reporting higher levels of perceived racial bias, also reporting worse health-related quality of life. There's starting to be research that's looking at the potential for underlying neurobiology of stress in the context of chronic pain and pain-related stigma, not just with sickle cell disease. And as already mentioned, experienced stigma and or mistrust in healthcare settings can influence readiness to engage in needed healthcare. And so that in turn is going to increase the risk of poor health-related outcomes. The sickle cell disease health-related stigma scale has been around for a few years, but recently was validated in terms of a short form. And what was found is that higher scores on the sickle cell disease health-related stigma scale was associated with increased depressive and anxious symptoms, increased perceptions of pain and pain interference, and diminished satisfaction with social roles. In a study comparing patients with sickle cell disease in Jamaica and the US, it was found that in both settings, that patients reported moderate stigma scores, and that these were related to concerns about people finding out that they had sickle cell disease, and also the expectation that they would be discriminated against. And so these reports were actually associated with worse quality of life. So now I am going to turn to this analysis that we did of sickle cell stigma from 3 African countries. This research was funded by the National Human Genome Research Institute and is a part of the Human Heredity and Health in Africa Consortium, or H3 Africa. And what H3 Africa, the goal of the consortium has been to advance the study of genomics and environmental determinants of common diseases on the African continent. And so sickle cell is rare in the US, but it's common on the African continent. The goal is really to address health inequities and improve the health of Africans, with one strategy being strengthening the research infrastructure on the African continent so that all of the studies are led by African researchers and teams are trained to conduct research with the latest methodologies, so that overall the goal is really to strengthen the research infrastructure. And this is important, again, in the case of sickle cell disease, where this modeling of the burden of sickle cell disease by 2050 shows that the African continent will bear the brunt of the burden of sickle cell disease, as well as India. And this is Nigeria and the Democratic Republic of Congo. So where we have about, again, 100,000 people with sickle cell disease, this number is up to 5 million in projected in Nigeria, Democratic Republic of Congo, and India. So understanding stigma and putting forward strategies for the best treatment is really critical. So our study explored perspectives and attitudes regarding genomic research and its implementation and implications in Cameroon, Ghana, and Tanzania. So we were the LC work group for H3 Africa. And our goal was really to, again, explore these perspectives and attitudes, both about genomic research and implementation, but also about sickle cell disease public health interventions. And this is my colleague, Rafa Salim in Tanzania. So we conducted a cross-sectional study using a qualitative methodology entitled Descriptive Phenomenology, which is just the understanding of people's experiences. A way to understand people's experience is to use purposive sampling. So you want to ensure that your participants are knowledgeable informants within the domains of interest. So our sample included people with sickle cell disease, but also healthcare providers, as well as community leaders and healthcare administrators in the general community, and not just the individuals with sickle cell disease, but also their family members. And this is our team in Ghana. The site principal investigators reached out in writing to potential key informants. They reached out to country and regional directors of health, heads of hospitals where patients with sickle cell disease were treated, and obtained formal permission from local authorities and community elders to conduct the research. So again, conducting research on the African continent really requires this respect and honoring of the local leadership. And so since our leaders were on the African continent, they were very careful about obtaining the correct permissions. And this is the scene of Yaoundé, the capital of Cameroon. Our participants were adults, 18 years of age and older. We sought to include urban and rural areas, since over half of people on the African continent do live in rural areas. And again, our inclusion criteria I already mentioned. And this was my opportunity to actually interview a traditional leader in one of the villages in Ghana. We created standard interview questions to elicit these perspectives on genomics research and its implementation and implications, perceptions of an experience with sickle cell disease and sickle cell trait, and had standard follow-up questions for vague or ambiguous answers. The interview guides were translated and back translated in French, Twi, and Swahili. And interview participants completed a demographics form. And where possible, which was the majority of the time, interviewers actually spoke French, Twi, or Swahili. I've already mentioned our in-country researcher recruitment, but we also brought everyone together to a week-long short course in Cape Town, where the PI, Ambrose Wankum, was at the time. And then we moved from our short course to in-country trainings with the local research teams. We had our site coordinator manual go through many iterations to be appropriate for different settings. And one thing that was pointed out to us, that it was, even for a research study, that would be important for our focus group participants to be assured of confidentiality. So when they signed their consent, we assigned them a number. And so then when we sat around in groups, people were only referred to by their numbers and not by their names. And this is just a schematic of our training, participant recruitment, and data collection. So we started with our pilot of our interview manuals and our training to solidify our interview guide and make a selection of who we would be interviewing in urban and rural settings. We identified our stakeholders and the community leaders who would be participating. And from there, you can see the number of people who actually were affected directly by sickle cell disease, people with sickle cell disease and their family members, as well as health professionals in the general community. And then where we could not conduct groups, we conducted individual interviews, both in urban and rural settings. And these were often with the community leaders or affected family members, with these same goals that I've mentioned already, looking at the perceptions and experience of sickle cell disease and sickle cell trait, genomics and public health interventions such as screening, prenatal diagnosis, and so on. And then perspectives on genomic research, which is more of the H3 Africa area that we're looking at, and I won't talk about that at all here. We had participants complete the demographic forms, as I mentioned, but the forms got lost somehow, and some of them in Tanzania, so I'm not going to report on their characteristics. But that's also an example of how, a global study can run into those kinds of problems where there wasn't a central place that we were keeping this data, and again, some of it did get lost, unfortunately. But in Cameroon and Ghana, you can see the breakdown by gender for this segment of the people participating healthcare providers, the level of education, and mostly the participants were in nursing or midwife, although a number of physicians. And then if you look at the people with sickle cell disease and their family members, the gender is pretty consistent with what we saw with the providers, but you can see that education, not unexpectedly, was quite different between the people participating who had sickle cell disease or were directly affected versus the healthcare providers. And then further, these are the occupations, with many in Cameroon being students, and many in Ghana being traders or individually employed. We took digital recordings from the individual and group interviews, cleaned them of identifying information, and translated as needed into English, and then transcribed them. And these transcriptions were imported into in vivo software, pretty common qualitative software. And we conducted successive coding passes, starting with a pilot coding system based in the literature, and then beginning to generate thematic domains through a process of review and discussion within each country, but then coming together among all 3 countries to update our coding scheme. So our results is this scheme of what the perspectives of sickle cell disease genomics and public health interventions were. And for sickle cell disease, main theme was related to knowledge and experiences of sickle cell disease. Stigma was a main theme. Education about sickle cell disease and sickle cell trait was an important result of what we found when we brought all of the themes and codes together. From the perspective of the genomics, ethical issues that's an important theme, as well as perspectives on research. And so you can see that it's a pretty complex mind map, if you will, of how these topics are interrelated. But we'll be focusing next on this aspect of stigma that came up when we talked about this in the context of sickle cell disease. So in summary, we were able to recruit a very large, diverse sample of stakeholders. And this did allow us to identify practical, psychosocial, and ethical challenges associated with general and sickle cell disease genomics research and sickle cell disease prevention and care in sub-Saharan Africa. And we did, with the work that we did, contribute to the development of the research infrastructure in the conduct of qualitative research with a number of aspects that I outlined. And this has been a productive group, just a few of our publications. And again, this one, Stakeholder Perspectives, is the one that outlines our methodology for H3 Africa in terms of qualitative research. So now we move into the further analysis of the data coded within the stigma themes. What we decided to do with this was to interpret the data within 3 conceptual frameworks. So first, the ecological systems theory that I showed earlier, where you have the structural, the community, the interpersonal, and the internalized. Then we looked at drivers and facilitators of health stigma and discrimination using a framework put forward by Stengel. And then finally, we looked at what our participants generated in terms of strategies to reduce stigma. And the framework that we used for that is the public health framework for reducing stigma. So 106 interviews contributed to this analysis. So these were where stigma was brought up specifically. And you can see the breakdown by individuals with sickle cell disease and caregivers and other stakeholders. And again, if aiming for about half from rural settings, which this may reflect that people with sickle cell disease need to be in urban settings to get needed care, because only in Cameroon were we able to get close to half in rural settings. So this is that social ecological model, just turned on its side. We weren't surprised that the major themes were really related to negative labeling and explicit bias. So people describe bias in education, in the workplace, in the healthcare setting. Negative labeling, rooted often in cultural and religious beliefs. And as well, again, impact on employment and particularly on marriage. But what we were a little surprised about was another theme that really came up quite commonly was pity or sympathy. So sympathy and pity don't sound negative, but they are very stigmatizing as much as explicit bias. And so we're a little bit surprised to find that theme. The others really did follow from the literature. And here, a healthcare provider from Tanzania really just described the levels of stigma, categorizing stigma in three manners. First, that a person is expected to not live long, to not live past their 21st birthday. And second, jaundice and other physical characteristics commonly associated with people with sickle cell disease would lead to superstitious beliefs about them. And thirdly, that misconceptions could be rampant, so that people felt that sickle cell disease might be spread, might be contagious, or that the person would bring misfortune to the family or the community. And this healthcare provider talks about the pity aspect and how it actually contributes to internalized stigma. So the patient is feeling stigmatized. People around that person feel sorry for them. They pity them, but then that frustrates the person. So drivers of in this health stigma and discrimination framework, drivers of sickle cell disease related stigma that we identified are these inherently negative influences. So again, this association with early mortality, frequency of pain and hospitalization, the physical features that I mentioned, social judgments that you saw on that first graph, such as the person is weak or lazy. And then the internalized components, self-blame and denial. The hereditary nature of sickle cell disease stigmatized families. Sometimes people were referred to as vampires because of the regular need for blood transfusions. And then this stigmatizing language, such as sickler. And so one person who cared for an individual with sickle cell disease captured in this quote, people always compare them to other children, and they give them all sorts of names like small body or I will die tomorrow. And that term obanji refers to a child that is born to haunt their parents because the child dies, and then when the child may be reborn again, and it haunts their parent if that child again has sickle cell disease. And not only the physical aspects of sickle cell disease, but sometimes people were stigmatized by a sign that was put on them. So in a setting where people can use corporal punishment, a red sign was put on the child with sickle cell disease so that the teacher would know they couldn't punish the student. And then further, the red sign would show other students that they don't have good health. And obviously this wearing this badge on the one hand was meant to elicit sympathy or pity, but it certainly propagated stigma. Now, facilitators of sickle cell disease related stigma are somewhat distinct from drivers in the sense that drivers push forward stigma, where facilitators just make it easier for the stigma to occur. So a context where supernatural beliefs are common, then sickle cell disease falls into that, where people are accused of being witches, or the fact that they have sickle cell disease, that there's a curse on the family. Also, these cultural beliefs. So the observation that people have children who have sickle cell disease when there isn't an understanding maybe of heredity. And then there's a cultural belief about marrying someone who has sickle cell disease or sickle cell trait because of the potential outcome. And this is rooted in a range of misconceptions. And then the pity sympathy that I've already mentioned. Then this being is viewed as weak and excluded from strenuous activity. And finally, the perception that this is a serious disease. That can be a positive thing, that you recognize the disease is serious, but again, it's also stigmatizing. So this healthcare provider in Ghana commented, people think they're witches and wizards. And again, it's when they see the physical characteristics, then people can be very fearful and assign supernatural kinds of causes to that person's physical differences. And then this person with sickle cell disease really talked about how that they were not felt to be very strong. And so again, you have this side of things where you're treating the person in a special way, but then it also is creating a stigma because they're being characterized as not strong and not able to participate in sports. So a third domain within the health stigma and discrimination framework is what experiences and practices manifest sickle cell disease related stigma. And so these domains actually correspond with those social ecological levels. So at the structural level, you have the employment discrimination or the discourteous treatment at health facilities, schools, workplaces. At the community level, the social isolation, the social discrimination in intimate relationships, this is also interpersonal, and then of course the internalization of stigma. And this was very common, forbidding the relative to have a relationship because of fear about the outcome. And in thinking about this was applying for medical school, where you have to, for jobs and schooling, provide a medical certificate about one's health. And if the person has sickle cell disease, then this person is saying that they wouldn't recruit them because they feel they won't be productive, or they may miss a lot of work or school because of hospitalizations and frequent pain. And then the last domain in the health stigma and discrimination framework is outcomes of sickle cell disease related stigma. So the explicit bias certainly negatively impacts health seeking behaviors of the person with sickle cell disease. And the person feels diminished and lacking in value. There are challenges with integrating them into the workplace and school. And so then this leads to concerns about disclosing that one has sickle cell disease, in particularly in the absence of the physical characteristics. And this came up quite a bit, that healthcare providers could be some of the worst in terms of stigma. So they would use all sorts of stigmatizing words, one word meaning I will die tomorrow, another money will finish. So in settings where there isn't national insurance, where many medical expenses are paid out of pocket, sickle cell disease is a tremendous financial burden. And so the child is characterized as depleting the family's resources. And then this person is detailing how they were considered to not, it would be a waste of money to send them to school because they weren't expected to live long, so they sent the brother instead. So what did some of our interviewees say about what we can do about reducing sickle cell disease related stigma? There were 4 areas that people commented on. First, education, and then advocacy, and support, and I'll get into the other areas, regulation, government regulations, but we'll start with education. So people who were interviewed really felt that there should be implicit bias training for healthcare providers, communities, and educators, and that there should be health programs educating people about sickle cell in schools, so people wouldn't hold these negative misconceptions about people with sickle cell disease, that they would have accurate information, and that media campaigns could raise awareness. And this particular framework also looks at how you can address the psychological processes that come along with stigma, so that parents should be receiving anticipatory guidance so that they can enhance their children's self-esteem, talk to families and individuals about the impact of self-stigma, internalized stigma, and I'll get into that a little bit more later. And just, again, self-advocacy, and finally, educating teachers about accommodations and inclusion. A religious leader in Ghana commented on this education that should go to different groups, healthcare workers and other leaders, such as religious leaders. And that's because they're so well respected and listened to. And then further, community nurses are very much an integral part of the community, so they really need to be educated, and so that they can impart, again, accurate information about sickle cell disease. And then the other areas in this framework are advocacy, again, contact, and regulation. So first, advocacy. So explicit bias needs to be interrupted. And so that workplace accommodation should be made, discrimination in the workplace should be denounced. And the negative stereotyping would be something that should be reversed. In terms of contact, just letting people know that sickle cell is common, that it has a medical or scientific basis. And so facilitating that awareness, particularly among religious leaders who, again, are very influential, was something that was brought up. And that would also lend to psychological and social support for affected individuals and families. And some noted that really ministries of health should be supporting psychological and social support. And then lastly, regulation. So sickle cell disease should be prioritized. Again, very common, a very big burden on the individual, the community, and the healthcare system. And so that there should be programs to reduce economic burden on the individual family, such as national insurance, but it would also reduce the burden on the whole society. And so there need to be policies and programs to address discriminatory practices. This administrator just commented on the contact aspect. People just need to be knowledgeable. When they're exposed to certain things, when they're sensitized, then they will be less likely to stigmatize. The approach is to educate. So let's turn back to the US. So when I showed you the domains of sickle cell related stigma, in this country, it's really seen as race-based. And this consensus report that was put out by the National Academies of Sciences, Engineering, and Medicine in 2021 really highlighted how we have to look at structural racism in this country. And so it's a similar, the issue is similar, but different in the sense of what's the root of the problem here. And so structurally, we don't have organized systems of care still for sickle cell disease. There isn't a national surveillance program. There isn't a consistent monitoring of quality of care, and there still aren't enough qualified health professionals. So this blueprint for action outlines strategies that need to be taken at the national level in the US to strengthen the system of care for people with sickle cell disease, and to really move forward with strategic partnerships, such as among Health Resources and Services Administration, CDC, NIH. And then an anti-racism framework, which we're all familiar with here at UCSF, recognizes that that racism is a system that affects all of us, and that we need to recognize and rectify historical injustices. Resources should be provided according to need. So sickle cell disease has suffered from lack of resources over the course of its, since it's been identified in 1910 in this country. So there needs to be influx of resources to catch up with where sickle cell disease should be compared with other diseases that affect primarily white populations. And we are really excited that we're in the place of deploying curative therapies, but we have to continue to focus on the lack of access to quality of care for so many with sickle cell disease. And so it does take dismantling racism at structural and policy levels, as well as interpersonal levels. I had mentioned earlier this internalized stigma aspect of things, and a nurse, Coretta Generett, actually a distinguished professor, created a two-part intervention where she taught people, adolescents with sickle cell disease, to speak up to get the care that they needed. So what she had was she coached them to use an organized way to talk to their healthcare provider when they experienced stigma. The second part of the intervention was to educate them about managing their pain early, to reduce the need for acute intervention. And they definitely found in a small randomized trial that this intervention was superior to an attention control arm in improving the adolescents' self-efficacy and communication ability to advocate for themselves. So this is very promising, and we really need to move forward with this type of an intervention. Other interventions for the internalized stigma part are support groups, empowerment and self-help, and again, advocacy and self-advocacy. Also trauma-informed care, where your whole team is really aiming to not enhance trauma, but rather to be an anti-trauma sort of focused approach. This is an interesting intervention from the Joint Commissions. Again, really important in the US and other countries where you have this race-based discrimination. And so they have the Speak Up campaign, which they encourage patients to speak up when they experience discrimination. And so this empowerment and self-advocacy can really go a long way. And then further, they have, if you can't get satisfaction at your local level, you can turn to the Joint Commissions or the Office of Civil Rights. And again, in the wake of the COVID-19 pandemic, the World Health Organization has a new campaign. Stigma and discrimination are never okay. Diseases can affect anyone. So this is a good time for the sickle cell population to align with a broader focus on solidarity, not stigma. So what are some future directions? So the H3 Africa is focused on research, but the Sickle in Africa Consortium focuses as well on clinical care. So within the Sickle in Africa Consortium, there have been policies that have incorporated these results from this larger ELSI study to guide recommendations for preventive and care policies, with the stigma results incorporated into those policies. Now, these aren't policies at the level of health ministries, with the exception of very few countries like Ghana and Nigeria. So that's a real area that needs to be focused on in Africa, where you have the government level of supporting people with sickle cell disease. That can happen with advocacy. So the H3 Africa and the Sickle in Africa Consortium do have strong community-based organizations that are partnering to move things along. And we have a grant here. So what are we doing again locally? We got an anti-racism research planning grant where we're going to use community-based research practices to advance anti-racism. And we're looking at, again, the structural, the interpersonal, and the individual levels. We're partnering with a community-based organization called Sickle Cell 101, and our Sickle Cell Center is partnering with the BCH DEI-AR Council. So the importance of these types of qualitative results, the importance of viewing them within a conceptual framework, is that this can lend to hypothesis testing. So these qualitative results can lend to hypothesis generating and again, these policies and practices, but ultimately we need to be creating interventions and studying them in a standardized, random way. So I'd like to thank you and also invite you to listen to our podcast about our Sickle Cell Center, and that I will stop there and take questions.
Thank you, Marsha. That was really interesting. Just while other people are gathering their thoughts, I had a question. I mean, clearly you highlighted the part around education and needing to understand, what the underlying condition was. It's not something you can catch, or, those kinds of things. But does any of this spill over into carrier status? And, you mentioned about marriage discrimination or marriage impacting marriage.
Yeah, definitely. So that a conception or a misconception might be that, a lack of understanding about a risk for each pregnancy. And so in other words, that the thinking would be that every child is going to have sickle cell disease, that it's 100%, not 25% if both parents have the trait. So that was a pretty common misconception. There weren't many others. I think trait, the issues that we saw really were associated again with marriage, not so much with the health of the person with trait, but more with reproductive decision making, and often again being forbidden to be married if the two people have the trait.
So some families though are completely spared, as that, or I mean, it seems like it's so extensive. No, I'm trying to just understand, like if you have a family history but you're not affected, do they, is there a discrimination based on that?
Oh, I see what you're asking.
Yeah. No.
Yeah. In my observation and in the research that we did, it would be more often that you would see that the family would be thought to be cursed if there was a child who was affected, and then that there would be a generational sort of concept that the family would be at risk again of having this cursed child, another cursed child. So in that sense, there could be real community stigma against a family if they have a history of a child with sickle cell disease.
I see. Are there other questions? Or?
Yeah, I had a question for Marsha. Marsha, first of all, thank you. That was really wonderful. I just have a question about maybe the other end of this stigmatism discussion, and that is, I've seen that reports in various advocacy groups that form around groups that have what have been considered to be abnormalities, genetic diseases, etc., where the notion has arisen. It's more, I think, more in Western societies, in some of these settings, that they resist the idea that there's something wrong with them, that it should be considered a stigma. You've seen, I think, the most of this in hearing impaired communities, where they don't want to be cured, even though if there's a cure coming out, they view, a cure would suggest that they're abnormal, and they resist that notion. And I believe that I've heard some of that within some groups within the sickle cell community as well, if I'm not mistaken. Just wondering if you have any knowledge of that or any thoughts about it.
Yeah, I mean, that's a really great point. And so what's really you have to think about with the curative therapies is really, what is the identity of the person? And so an identity that where sickle cell disease, there can be these different levels where it's overwhelming, where it's accepted as a part of you, or where it's seen as you want to keep it at bay and you don't want to think about it, you're in denial about it. So these different levels of identity about how sickle cell fits in to your whole being really can influence a person or family's willingness or ability to move forward in thinking about a curative therapy. And so many people, I mean, I've heard patients or people who were cured, who went through stem cell transplantation or gene therapy, who have said, they did have to think about, what will my life be like if I don't live with this pain every single day? What will my life be like if I don't, have, it's such a strong influence on how a person lives in their world. So it's not uncommon to think about that. A cure, quote, cure, may or may not be, the uptake may or may not be there for certain populations. At the same time, what people really need is, so first of all, the provider has to think about, what's the person's identity in relationship to their disease. And like you said, in the hearing community, or people with hearing differences, it may be that it's not seen as something that should be changed. But in the situation of sickle cell disease, again, it could be something else. It could be denial, but again, it also can be this embracing of the identity, and then there's not a need for cure. But I think that it just takes trusting relationships, honest communication, transparency, all of these things. Our community partners have let us know that these can really help people to make informed decisions, and that as providers, we can't just decide, what's the best for the person. We have to really partner with them to understand, what is their concept of this disease in the context of, again, I would say, their identity. I will say that where I've heard people express concerns about the curative therapies, that many people get on the other side and say they were glad they did it. so they talk about, it took a while for the pain to go away, and they recognize that certain complications don't change because they don't have sickle cell anymore. But it's pretty common that people say they are glad that they went through the curative therapy. So there's a comment, as I had said earlier, it's true that it's not just about the individual advocacy and empowerment, but in the African countries, what the participants commented on was regulation. So regulation to prevent the workplace discrimination, the educational discrimination, the community discrimination. And in this country, you have to operate at the structural level. So you so for example, that we did a study where we embedded individualized payment plans in the electronic health record. And so that can cut through the structural racism because the individualized payment plan is right there. There's not an argument about it. There's just no argument about it. And so that's the structural level. But then you have these interpersonal, you can't forget the implicit bias of the healthcare providers. That's how the racism plays out. So it does have to happen at every level, not just structural, not just regulation, but as well interpersonal. And the individual, it needs the support to manage what's coming at them.
Marsha, I'm struck by sort of the cultural context within which the stigma happens, right? So you have African studies that are, not necessarily sort of have a racial component to it, and then you have the racial component here in the US. You also mentioned a large number of sickle cell patients in India. Has anything been done to see what kinds of issues lead to stigmatization in India?
That is a really great question. I would say that for whatever, when I haven't spent as much time in India as Africa. In fact, very little compared to the amount of time that I've spent in Africa. But there can be the social determinants of health can really operate around the world, so that people's educational level, their access to education, their access to housing, their access to clean water, nutrition, safe neighborhoods, all of that can come together in a negative way. And so that populations can be made vulnerable by their systems that they're in. And again, in my understanding, there are populations who are more affected in India, and but I mean, it's not my area of expertise at all. No. But in my observation, the issues of social determinants of health around the world really do pile on people these issues of, again, poverty, lack of access to education, and so on. It's a really great question, and it's a really important area where it really should be studied, because there are other levels of stigma in relation to other diseases and other things as well in that setting.
Yeah, I mean, just a simple thing would be, relation to the caste system, for instance.
Yes.
Right. Yeah.
Exactly. Yeah, and I'm just not aware if the caste system and sickle cell are in interplay at all. I wouldn't be surprised if they did.
Yeah, Ellie added into the chat, says many are Aboriginal, already stigmatized. Is that referring to India?
Yeah, I think probably.
Yeah, okay. All right, thank you. Any further questions? Anyone? Comments? All right, thanks again, Marsha. It's fantastic.
All right.
Really,
have a great summer, everybody.
All right, bye, everyone.
Take care. Bye.